Hello everyone, I'm Donald Manlapas and I'll be your lecturer and facilitator for our third module or session for musculoskeletal examination. And our topic for this session will be differential diagnosis and principles of special tests. So the American Physical Therapy Association Vision 2020 is that physical therapists must be able to engage in diagnostic process as part of their overall evaluation and leads to a decision regarding probable pathology. I got this quote because of relating the term diagnosis and probable pathology for specific individuals wherein physical therapist is engaged in everyday dealings in the clinic. So what is diagnosis? So the anatomic, biomechanical, and physiologic or psychological derangement. Okay? So there's a diagnosis based on the pathophysiology, based on the anatomic structure being observed or being manifested by your patients or by any individuals with a condition. There's also a physiologic and psychologic now derangement, meaning there's a disequilibrium, particularly in the body system. And in giving the diagnosis, it should match with labeling of the pathology. Sometimes the basis, most of the time, of the diagnosis is based on the pathology itself. But diagnosis in physical therapy parlance is that diagnosis is the term which names the primary dysfunction towards which the physical therapist directs the treatment. Without proper diagnosis, without proper examination of your patient, you cannot arrive to a specific working diagnosis for your patient. Why? Because this is very important in your treatment planning. Okay? Even though your treatment are evidence-based, backed up with research, you have a good protocol, you have good frequency, treatment time for your plan, but if you don't have the correct diagnosis for the patient won't be healed or cured from its condition. So most important, before you start anything, you should have a good probable diagnosis. But how can we arrive with this diagnosis? Okay, so some important definitions for diagnosis, for particularly for the doctors, they use the medical diagnosis such as herniated disc and cerebrovascular accident. So they base on the pathology and condition itself. But if you look at the diagnosis of physical therapist, um, we focus, as I mentioned, we focus on function. Okay, we put now the limitations. Okay, so for example, right-sided radiculopathy centralizing with repeated extension. Okay, the diagnosis of that patient medically, the patient has maybe L4 L5 herniated disc, but for us, we see that there's centralizing pain, maybe pain or radiculopathy upon extension. So there's a function, or it can be a stages, or we use some criteria or a development of a condition, particularly stages, types, okay, based on the recovery of your patient. So example is a left-sided hemiplegia, Brunstrom stage 3, all movements in synergy with marked spasticity. So all movement in synergy with marked spasticity. So there's a problem now in the tone, okay, of the muscle of the patient. Okay, particularly on the left side, because this patient will have a cerebrovascular accident. Okay, so that's the difference between medical diagnosis and PT diagnosis. In our setting, we usually use the term PT impression, and the physical therapy musculoskeletal 2 intervention and an evaluation, they will teach you how to write this one. Okay? But for now, we should have a working diagnosis, and that diagnosis is based from the evaluation that we are doing. Whether you're using ROM, MMT, reflexes, sensory assessment, neurologic assessment, functional analysis, postural assessment, gait analysis, and of course, one of the most important is of course your subjective history taking. So, based on those data, based on those information, you will arrive in your PT diagnosis or your PT impression. So, what are the different stages of a differential diagnosis? So, for example, you have a diagnosis in the patient A, okay, and the patient will have some symptoms, okay. They are presenting some signs and symptoms. So, the first stage is what we call pattern recognition, wherein there's actually a realization that the patient conforms in a previous learned pattern of the disease. Okay? Like for example, they felt that, parang nangangala yung shoulder ko. Every time nangangala yung shoulder ko. Okay? So, usually it's reflexive but not reflective. Usually not cannot be explained to others, and they argue that it is actually learned from the patient and not being taught in the lecture halls. Why? Because at the first, maybe you're just a beginner, you just base it on what most of the patient will tell you, and sometimes that pattern recognition will lead you to a specific diagnosis. Okay. Next is what we are doing a bit. If you're a novice, if you're a novice physical therapist, then you can do your complete history and physical examination. Sometimes it's impractical because when you talk about complete history and physical examination, you do assess all the system, you do examination of all the systems. Okay? But it's impractical and sometimes inefficient. But as you hone your skills in doing an examination, there's what we call your hypothetical deductive strategy, or you give an hypothesis and you deduce something from the list of initial examination that you have. Like for example, we have a patient with adhesive capsulitis. Okay, you know that if you have an adhesive capsulitis, the most predisposing factor is immobility, right? Usually because of pain, it was immobilized, etc. You're not moving your shoulder. Okay, that's the most common. Okay, predisposing factor. But at the same time, you know that in adhesive capsulitis, the main pathology or the problem is the capsule. And in every joint, particularly in the shoulder joint, there's what we call capsular pattern. So, your examination will deal more on examination of the range of motion, the limitation of motion, wherein you will try to see if there's a real limitation on that specific pattern, so that you can zero in that this is not a problem of a tendon like supraspinatus tendinitis. There's no inflammation of bursa. There's no fracture, but it's more on that capsulitis pattern. And you can deduce from that. So it is not only the range of motion, but you do subsequent tests to perform and confirm. And that's the reason why we are doing, and we will discuss later on, special tests or special maneuver done by physical therapists. Okay? This requires an understanding of probability. So like zebra versus horses, like it's like zero, like your toss coin, right? It can be yes, it can be no. Why? Because we go back to our ancillary procedures based on the medical notes. That's the reason why there should be a collaboration, an interprofessional collaboration between the doctors, the rehabilitation doctor rather, and the physical therapist. Okay, they need to talk so that they can have a good working diagnosis. Okay, so the doctor will give a medical diagnosis, and for us, we can have a PT impression. Okay, and sometimes the doctor will tell you, for example, a condition A, rule out condition B. Okay? So there's a working diagnosis for the patient, not yet final. And as a physical therapist, because we are the expert in movement and function, okay, muscles, then what we can do is actually to give a rule out test for them. Okay? So these are the three again: pattern recognition, complete history taking and examination, and hypothetical deductive strategy. So, what are the different components or approaches that you can get so that you can have a good working diagnosis for your patient? First is what we call past medical history. That's very important. Whether the patient has hospitalization before, okay? Whether the past medical history, there's a pertinent information, particularly in that specific region, maybe in the elbow, maybe in the wrist and hand, okay? The history of present illness. You all know the HPI of your patient. Like for example, 2 months ago I had a trauma. 2 months ago I felt pain 10/10. Okay, I was asleep, and then after that I felt that there's pain on my hip area. Okay, or in the morning I felt pain upon giving load or weight bearing on my foot. Risk factors. As I mentioned, risk factors is very important because this can also deduce some of the ideas or pathology that you have in your mind. Okay, so risk factors can be internal and external, or intrinsic or extrinsic. So intrinsic risk factors are the age, gender, family history, while extrinsic risk factors includes lifestyle. For example, if the patient has hypertension, etc., etc. So these are the extrinsic risk factors. Okay. While your clinical presentation are very important. That's the reason why your background in your MS1 and in your anatomy and physiology are very important because this will lead you to a good and accurate diagnosis of your patient. Okay? Pain patterns are also important. So we're talking about sometimes systems approach and what we call condition-based approach. Okay? So these are the two approaches. Okay? When we talk about system-based approach, we talk about a specific system in the body, like for example, sensory system or maybe sensory motor system. So based on that presentation, based on your observation in that specific system, you can now differentiate. Okay, you can now differentiate different conditions. Okay, like for example, you have a patient with problem with pain, then you might think of like maybe we can assess the different elements of the pain. Okay, so you may also want to check the sensory testing. Okay, while condition-based approach, you are differentiating different conditions on a specific area. Like for example, in the shoulder. Okay, condition for example, impingement syndrome. From the word syndrome, the meaning of syndrome is actually these are actually collective signs and symptoms or collective symptoms of a patient. It becomes a syndrome as a whole. It's a big umbrella. Okay, so there's an impingement syndrome, and what's causing now the impingement now in the shoulder? There's a lot, right? It might be the bursitis, right? Or for example, the condition is all about the tendons. There can be supraspinatus tendinitis, bicipital tendinitis. So you try to differentiate those things. So I'll give you some examples. So for example, system approach, you want to check pain assessment. So of course, you need to quantify the pain. Quantifying it by using subjective pain scale, 0, no pain, 10, worst possible pain. Visual analog scale. So visual analog scale is actually a 10 meter, not 10 meter, 10 cm rather, 10 cm line wherein the patient will try to draw where's the specific or mark where's the specific pain. Like, and then you measure that. For example, at this line, there's 3.5 cm. So the pain is around 3.5. Okay. Some will use body diagrams and pain charts, okay? But most of us will use what we call an outcome measure tool. And the most commonly used and what's most important about pain is by using the McGill Pain Questionnaire. Why? Because pain is not just about the sensory, the feeling of the unpleasant feeling of your patient, but pain can also emanate with other things and can be overlapping with cognition, with emotions, with behaviors. And these are the aspects seen in assessing now pain of your patient by using McGill Pain Questionnaire. The other one, maybe you can check also for the irritability of the region by checking the pressure threshold meter, the pressure, by using dolorometer or what we call algometer. Most commonly, they use the word algometer because algo also means pain, a pressure, and dolor means pain. So for to qualify, okay, you might want to check for the duration, whether it's intermittent or insidious. Okay, so it can be on and off, or it can be like every any movement, rest position, still there's pain. Okay, the other one is the onset. It can be sudden or insidious. So gradually, and or insidious, or it can be like a trauma, sudden onset of pain. Localization is very important. So, it can be localized, diffuse. So, patient will tell you, dito lang, or kumakalat, or parang dito sa area, pero parang hindi ko alam kung saan. Okay? Or it can be radiating. Because this one will tell you, might be peripheral nerve problems because there's a radiating pain complained by your patient. And then, the type, if it's dull, aching, shooting, and everything. So, for the type, we can actually differentiate that with different structures. Like for example, if the patient will tell you sharp shooting, then it can be a nerve root pain. Sharp, bright, parang lightning-like, it's a nerve pain. Burning, pressure-like, it's more on sympathetic nerve pain. But those structures are more for the peripheral nerves, right, or the nervous system. But if it's boring, usually it's bone. If it's severe, intolerable, then it's fracture. The word cramping, okay, will suggest maybe a muscle pain, and throbbing pain more on the vascular pain. So these are key words, okay, description coming from your patients that will give you might as well the origin of the specific pain. And therefore, given that, you can now deduce and differentiate that from the other conditions. Other considerations, maybe you want to check if it's chronic or acute stage. So if it's acute, the presentation of the patient is more on that the patients are anxious, okay? While chronic, it's more on that they are depressed and they're used with that specific pain. Okay, so those are manifestations that you will see in your patient. Maybe it will actually observe during your history taking if the patient is very responsive in answering your questions, or the patient is going out of your questions and telling other stories. So you can see if it's acute or chronic. Aggravating and relieving factors, of course, the time of the day is very important. Is that every morning? If is that rheumatoid arthritis? Is that osteoarthritis? Wherein in the morning you have pain, okay, upon moving, there's a stiffness, okay. Particular activity, okay, like for example, if the patient has a sedentary lifestyle, or the patient is actually stressed at work, okay, or leisure activities. Are there any aggravating movements or aggravating factors, particularly the activity the patient is doing? Okay, pain on activity decrease with rest. Maybe the patient will have musculoskeletal mechanical in origin, meaning mechanical low back pain, for example, wherein, okay, I'll rest and then there's no pain anymore. Okay, but upon activity, again, it increases. Morning pain that improves with activity. A good example of this one is osteoarthritis. Night pain or nocturnal pain. This can be a red flag sign of a possible maybe cancer or malignancy, or any type of nocturnal pain that will lead to this red flag. But this is just one. You can also include, like for example, what I mean is that hindi naman porket nocturnal pain, cancer na kagad. No, there are different red flag signs. Like for example, decrease in weight, sudden decrease in weight, then decrease in appetite. So these are the one of the factors that you need to consider. And I want to highlight this one, that night pain is not, or nocturnal pain is not, for example, you're watching TV or Netflix at night, and then suddenly you've felt pain on your hip area, and then, oh, this is a nocturnal pain. No, it's not nocturnal pain. You're sleeping and suddenly you wake up because of that pain. Okay, that's nocturnal pain. So natutulog ka na, bigla nagising ka sa sobrang sakit. That's nocturnal pain. Okay? Pain not affected by rest or activity might be fracture. Pain not affected by rest or activity, you might suspect fracture in this information. Next, let's try condition based. So I chose knee, for example, this one I chose knee. So particularly you have your ACL, your cruciates, okay, and you have your meniscus, particularly your medial meniscus. ACL, PCL, so medial meniscus I didn't put now lateral meniscus because medial meniscus is more commonly damaged or involved, okay, than the lateral meniscus. So during your history taking and during the mechanism, you can really do some differential diagnosis already based on the condition. Like for example, when you have cruciate problem, whether it's ACL, PCL, most of the time the patient will complain of instability. So the patient will have instability. So parang there's giving. Okay? There's a giving of the joint. Yan ang sasabihin ng pasyente, parang bumibigay. There's an instability giving of the joint. But when you talk about now meniscal, if you want to zero in that this is an ACL or PCL, you want to, of course, rule out if there's a meniscal problem. But if it's a meniscal problem, the usual complaint now of your patient is para siyang naglalak. Okay? There's a locking sensation. Okay, upon movement of the knee joint, there's a locking. So lock, okay? Nag-lock siya, parang nag-stop siya konti. So you do your further history taking, okay? Ask questions. And upon history taking, whether it's ACL, PCL, during that specific incident, they heard popping. Okay? So parang may nag-pop. Yun ang inalaman ko 2 months ago. Parang may nag-pop nung nangyari yung incident. Okay? When we talk about meniscal, it's not anymore popping. It's not anymore popping of the ligaments. So it's more on like parang may nag-click. Okay? So these are keywords again. So during your examination, for example, a patient complains of clicking of the joint. O alam mo na medyo, baka meniscal yan. Okay? Meniscal ang problem natin. Okay? The patient complains, 2 months ago, the patient complains during the incident, popping sensation. Maybe crochet. But let's talk about now the mechanism. Okay? Usually, ACL, sasabihin nyo, so paano po nangyari? Okay? So na rin yung pop. Ano po ba yung posisyon ng tuhod nyo? Sabihin niya, usually, this is in an extended position of the knee. Okay? Extended. And there's actually twisting. Okay? Twisting of the legs. Okay? Particularly in the knee joint. Okay? For PCL, it always happen during a flexed knee. Okay? Pag naka-bend yung knee. So nangyari na 'yon, parang nagda-drive ako. Okay? Nagkaroon ng accident, okay? And yung nag-drive siya, nakaupo, flex ang knee. Okay? Okay? So baka PCL 'yon. Okay? Flexed knee. It's always happen during the flexed knee. While for your MCL, usually there's a sudden internal rotation. For your, not MCL rather, but for your medial meniscus, there's a sudden internal rotation. Anong tumayo ako, tapos parang napaloob ko yung tuhod ko eh. Okay? From sitting position to standing position, bilang napaloob niya. Okay? So there's a sudden internal rotation. Okay. So those are the things that you can do a differential diagnosis already, whether it's cruciate problem or a meniscal problem. When we talk about now imaging, mostly in ACL, there's negative hemarthrosis. So, hemarthrosis. So, there's a negative hemarthrosis, meaning walang dugo. There's no blood inside the joint. So, it's also true when you talk about now PCL. Okay? Sorry. It's also true when you talk about now PCL. But in MCL, this one is already positive. Why? Okay, let's go back again to your anatomy and physiology, right? Remember that PCL, your cruciate ligaments, ACL and PCL are found intracapsular extrasynovial. Okay, we usually use the term ICES, meaning intracapsular extrasynovial. They're inside the capsule, but they're outside the synovium. So therefore, usually, there's no blood, okay, in the joint area. Okay? But remember, similar with your PCL, but remember, when we talk about now meniscus, okay, remember that meniscus has a blood supply. So whether there's a bucket handle tear or a longitudinal tear in the meniscus, then there might be blood in that specific area. So these are the findings that you can check. Okay, there's still a lot, but you can compare and contrast. But these are some of my example for doing a condition-based approach rather. Okay, to further this one, of course, we need to do our maneuvers. And we call this one your special test. Okay, this performed after completion of the history, observation, and evaluation of movement. Okay, as mentioned, special test is and any other painful assessment are done last. Okay, sa dulo sila. AKA, so also called your clinical accessory provocative or structural test, strongly suggests a clinical disease or condition when they yield positive result. And the caution does not necessarily rule out the disease or condition when they yield negative results. Okay. So what are special tests? These are findings of the test depend primarily on the skills and ability of the examiner, the physiotherapist, or physical therapist, and on the patient's ability to relax while the test is being performed. Okay? More accurately performed, for example, if there's a trauma or injury, right after the injury, under anesthesia and chronic conditions. But you need to be careful in doing this one. When you become an intern, you'll be assisted also by your clinical supervisors before you're doing it independently. And it takes a lot of practice and skills to do it. So most has one of the controversies of special tests. A lot of literature and journals are now saying that special tests are really not good. Okay, so what I'm trying to say here that most have not been tested for reliability and sometimes the validity may be questioned. Should not be used in isolation. It is not necessary to learn all special tests, so you're happy. Not all will be memorized, okay? Prefer to use those to be clinically significant. So this slide will tell you that if you our main book is your OPA, your Orthopedic Physical Assessment by David McGee. There's a lot of special tests, okay, listed in that book. But we need to check the validity, reliability, as well as the sensitivity and specificity of that specific test. Okay? So make sure we will guide you as we go with the different region in MSK. We will focus on the good clinical or special tests. So, what are the uses of your special test? So, to confirm a tentative diagnosis, so you have your working diagnosis. And of course, by doing this one, you make a differential diagnosis, okay? Because you're checking the structure based on the maneuver, based on kinesiologic and pathomechanical basis, okay? You differentiate between structures. As I mentioned a while ago, it's bicipital tendinitis or maybe supraspinatus tendinitis or ACL or MCL. Okay, so to understand unusual signs and to unravel difficulty of signs and symptoms. When I talk about now signs are more objective findings, while symptoms are more subjective findings. Okay, so that's the difference between signs and symptoms. Signs, these are objective findings based on your observation, while symptoms, usually these are subjective, okay, information given by your patients. So some precaution for the use of special tests. Care should be taken when performing special tests and should be done with caution. Okay, as much as possible, done also with some assistance. Okay, if you're new. So what are the contraindications of the use of special tests? If there's severe pain, you don't do your special tests. Acute and irritable condition of the joints. Instability. Osteoporosis. Okay, particularly if the patient also taking some medication like steroids that can lead laxity of the joint, and maybe if you do your special test, you might tear those ligaments and structures. There's a pathological bone disease, active disease process, unusual signs and symptoms. Okay, very unusual. Maybe you want to refer back the patient to the doctor again. Major neurological signs and patient apprehension. Okay, so these are the contraindications for the use of special tests. So the next slide will be about the different joints and the most common special tests and conditions found in that specific region. So here, what I want you to note at this level is to know if this special test is test for what specific joint, and the other one, this test is used to confirm what specific condition or pathology. Like for example, here in the shoulder, you can check for instability, pathology, and the impingement test. Okay? So as we all know, shoulder is the most unstable joint in the body. So there's a lot of structures that can be irritated and can be damaged as well. So this one is what we call Apley scratch test. So this one is Apley scratch test. So Apley scratch test is the quickest way to check the range of motion, of the shoulder. So you ask the patient, right shoulder to move, okay, up, okay, towards your scapula. So it means that on this side, the patient's shoulder is actually in external rotation, flexion, and abduction. Okay. While on the other hand, you have a patient now, you try to reach for the back, okay? And then the movement now here is shoulder extension, adduction, and internal rotation. So this is the quickest way to to check the range of motion of the shoulder. It's just like, for example, unhooking a bra for a female, okay, or unhooking the bra. There's a lot of style, so but I can give that as an example. And this one is already a special test. Okay, we call this one your aptly scratch test. Okay, it is also to check the range of motion of the shoulder, right? For shoulder instability, I want you to note of the load and shift test. So this is load and shift test. Um, okay, load and shift test. Sorry, load and shift test is the figure below. So the patient is sitting, and you try to do anterior and posterior instability, or you can do your apprehension or crank test. Okay, also for anterior posterior instability. Again, these are the special tests for the shoulder testing instability. You may also want to check the instability of the joint inferiorly. Remember, the most common dislocation is antero-inferior, right? Or anterior is the most common, but the weakest point is the anterior and the inferior region of the shoulder. So sulcus test and Fayet-Jeans is for inferior instability. So the figure above is Fayet-Jeans test, while the figure below is what we call sulcus test. So they try to pull down the shoulder, okay, to check if there's an instability, if there's excessive movement, okay, towards inferiorly, okay. Then you can check shoulder. You can check also for the connective tissue pathology like Speed's test and Yergason's. Speed's test is the figure below. So you want to irritate the bicipital tendon particularly, so that you can confirm that it's bicipital tendinitis. Above is actually your Yergason's test. Okay, remember that that the elbow has a function in your forearm, supination. So if you look at the arrow, the patient is doing supination while doing external rotation, while the therapist now resists that movement. Okay. Another one to differentiate bicipital tendinitis is what we call supraspinatus tendinitis. Okay, you can use your empty can test or drop arm test. So this figure is empty can test. Impingement. So, okay, if there's an impingement in the shoulder, you use your Neer's impingement test. Okay, so those are common tests used for the shoulder. How about for the elbow? Of course, for the elbow, you will hear, maybe instability or epicondylitis or lateral epicondylitis. So, for ligamentous stress test, so since elbow is a hinge joint, you can do your valgus test or varus test. Valgus test is actually giving a stress coming from the lateral side. Okay, so for example, you want to force now. You want to give a force coming from the lateral side. So the word valgus, there's a letter L, so it means lateral. So the force is coming lateral. What specific ligament you are testing? Your medial side. So it means that if you put a stress on you put a pressure coming from the lateral, you are checking the stability of your medial collateral ligament of the elbow. Therefore, if you're doing valgus stress, you are checking on the medial side, the medial collateral ligament. While for the varus stress test or varus test, the stress is coming from the medial, you're giving now stress on the lateral side. So, if you are now, for example, ask you to check for the stability of the medial collateral ligament, okay, of the elbow, you will use valgus or varus. Valgus stress test, letter L, because again, you give a force on the lateral to check the medial collateral ligament. And it's true for every hinge joint in the body. Like for example, for the knee, for your eyepiece, your interphalangeal joint, you can do a valgus and varus stress test. For epicondylitis, I think this one's very common to you. We have Cosen's test, Mills test, okay? Or the other one is method 3, what we call Maudsley's test. There's a new name for that, Maudsley's test, okay? So these are the compositions. So Cosen's, Mills, and method 3 are Maudsley's test. You can open your McGee to check how they do this one, whether it's an active or a passive test, okay? Of course, for your medial epicondylitis, you have your golfer's elbow test. So you want to stretch now the medial side of or the flexor muscular component of your forearm. So remember, if lateral epicondylitis, right, it's more common with the tennis player, right? So tennis elbow. This one is more on golfer's elbow. So you need to stretch now the common origin of the flexor muscles of your forearm. For the wrist and hand, there's a lot for the wrist of hand, but again, I want you to take note region, what specific test, specific condition, what specific test. Okay? So ligamentous instability and piano key test for instability in the wrist and hand area. For the hip joint, okay, I just want you to note for the pathology and tightness. The most common for hip pathology is what we call Patrick's test. Patrick's test is also known as your figure of four test. So it means that your hip, you try to put a figure of four in your legs. Okay, so for example, I put my legs, my right hip into external rotation, flexion, and abduction. So you have the figure of four. Okay, Patrick's test or figure of four test. Sometimes we call this one your Faber's test. Faber, flexion, abduction, external rotation of the hip. Okay, so to check if there's a hip pathology. But most common for the hip, of course, is the tightness. For sure, you have tight hamstrings, tight rectus femoris. Okay, so these are the different special tests that you need to take note. More common special tests. Sorry, we have your Ellis test. So the Ellis test, the first one is for rectus femoris. Hamstrings contraction test, tripod sign, 90-90 leg raise testing. These are all for hamstrings. The second, third, and the fourth. The fifth one, Ober's test, is for your ITB, iliotibial band. Again, Ober's test is for your ITB, iliotibial band. While your Phelps test is for your gracilis muscle. Okay? Next in the knee joint, there's a lot for your knee joint. So it can be ligaments, cruciate, meniscal, and patellofemoral. Of course, as I mentioned to you, you have your valgus and varus test. Okay? So the valgus and varus test, okay, will give you same similar test with your elbow. So again, valgus is for your medial collateral ligament of the knee, and varus stress test is for your lateral collateral ligament of the knee. So almost similar, okay? Similar with hinge joint in the body. For your cruciates, we have your anterior posterior drawers test for ACL and PCL respectively. Lachman's test is more for anterior cruciate ligament, and your pivot shift test if there's some rotatory components problems in the knee. Okay. For meniscal, we use Apley's and McMurray. So be familiar with Apley's compression test and McMurray test for the meniscus. And of course, we cannot go away with the patella, so you can use the Clark's test and your Waldron's test. So again, this will be discussed when we go to the knee region, I think during the third shifting. Okay? And for the ankle and foot, we'll have your Taylor tilt, Kliger's test, and your face line test. So you need to brush on this special test listed here in your book, in your Magi. Just this special test. You don't need to memorize the position. You don't need to memorize first how the maneuver. Again, it's the joint and what specific test is that particular special test is for. Okay, whether connective tissue, ligamentous instability, or maybe a muscular problem or a tendon problem. All right. So thank you for listening. Usually in the real face-to-face, we go with the activity that I've posted in the Blackboard. So so I'll move out. Okay, this one. So for your activity, you'll have